Vermont 55 KRC, the talk station.
845 at 55 KRC, talk station. I love it when the doctors from OHC are in studio to talk about all the advancements they are making in cancer therapy and treatments, and it's always a really positive discussion in spite of the fact that we're talking about something that absolutely sucks, cancer. It's one thing that everybody, regardless of political stripe, can agree on. And Dr. Akash Mukherjee is in the studio. He's an OHC hematologist and medical oncologist. He deals with blood and marrow transplants and cellular therapy, and he sees patients out of the OHC Kenwood location. That's a Jewish hospital. That's where I go. He's also involved with clinical trials, which we're going to be talking about today, and is the principal investigator for all lymphoma clinical trials at OHC's Cancer Research and Clinical Trials Program. Today we're going to be talking a little bit about CAR-T therapy, which OHC was the first practice in the tri-state to offer, but also BiTE therapy. Dr. Mukherjee, it's awesome having you in studio, and I appreciate you doing your little evaluation of me, considering we were talking about my low-spectrum lymphoma. Listeners know all about it. But what are these treatments that I just mentioned, BiTE therapy and the CAR-T? What are the treatments, and how do they work in connection with blood cancers? But I understand that you're evaluating them also for solid tumors, like a new chapter in this therapy.
Mm-hmm. Thank you so much, Brian, for having me here. The treatment landscape of cancer is changing so rapidly. When I was doing my fellowship, all the frontline treatment which we had several years ago, and that was like 10 years ago, has pretty much most of those cancers have changed by now.
Yeah.
And the immunotherapy is making a whole lot of progress. And, back in the old days, the treatment paradigm for cancer used to be, conventional surgery, radiation treatment, and chemo. But now we have more understanding of the cancer genomics and how it intertwined with the immune system. And our immune system actually plays a very important role in keeping the cancer in check and eliminating the tumor cells from the body. So immunotherapy, right now what we have is the BiTE therapy, which I'm going to talk, which is an antibody-based treatment. And what it does is that antibody, it has two arms. With one arm, it binds to the tumor cell, and with the other arm, it binds to the T cells, which are our immune fighting cells against the cancer. And it brings them closer together where the immune cell can destroy the cancer cells. So those are your BiTE infusion therapy, and they have been approved for several hematological malignancy, including ALL, acute lymphoblastic leukemia, lymphoma, as well as myeloma. Recently, OSC started using BiTE therapy. In fact, we were one of the first treatment center in entire state of Ohio to offer this BiTE treatment for small cell lung cancer. So the field is rapidly changing, and it's making its way in several other solid tumor, as you've been explaining. And I'm going to go into a little bit more at depth about it.
Yeah.
With the BiTE therapy is essentially, antibody-based infusion, and those patients get it every 2 or every 4 weeks, depending on the type of cancer and the type of drug which you are using. The CAR-T therapy is more potent, I believe, and it's a one-time infusion. And what essentially you do is, as I said, your immune cells play an important role in eliminating the cancer. And cancer happens in the first place when your immune cells are not able to recognize the cancer cells, or by some mechanism, your cancer cells are able to evade the immune response, and that allows them to grow in an uncontrolled, abnormal, and excessive fashion.
Yeah.
Now, what if you can harness those immune cells from a patient body, which we call leukapheresis, and you can ship off those immune cells to a GMP lab where they could be genetically modified and armed with a T cell receptor, which goes after a particular protein expressed on the surface of the cancer cells. You can expand those T cells, the fighting cells, or which we call CAR T cells, and then those product, it takes them roughly around 2 to 4 weeks to manufacture that cell product, and then they get shipped back to us. and then we give it to the patient very as simple as an IV transfusion or a blood transfusion. And it roughly takes around 15 to 30 minutes. And once those CAR T cells have been infused back into the patient body, then they kind of go into your circulation, and they have that genetically engineered receptor, the CAR T receptor.
Goes right to the cancer.
And it goes right to the cancer. It latches itself to the cancer cell, and it destroys the cancer cell. So it's really fascinating how it works. And, the CAR T treatment itself is undergoing evolution. But just to give you an idea and to your viewers, back in the old days, and I'm talking before we had the Yescarta for diffuse large B-cell lymphoma, which is a CAR T product. Patient with relapsed refractory lymphoma, once they have failed conventional line of chemotherapy, their median survival used to be, unfortunately, only 6 months or less. And the response rate with your conventional salvage therapy, the complete response rate was around 7%. So it was pretty dismal. But then with the CAR T therapy, now their complete response rate is pretty much 60 to 70%.
That's amazing.
With an overall response rate of 80%. And you can pretty much cure 40 to 50% of those patients.
That is absolutely amazing.
So yeah, it's been great, and we have had similar success with relapsed refractory myeloma as well as certain leukemia, and now we are slowly figuring out a way to beat solid cancer as well. And in that regard, OSC was one of the 11 clinical trial sites in the country who has been fortunate enough to use CAR T cells against HER2 positive solid tumor. So there are certain solid tumor like breast cancer, lung cancer, certain GI cancer, cholangiocarcinoma, which do express this protein called HER2. And you have CAR T cells which goes after those HER2 protein. And we just recruited our first patient, and she's undergoing through this study, and she has relapsed refractory cholangiocarcinoma. So, the field certainly looks promising. The early clinical trials certainly looks very hopeful. So, there is a lot more to come in this field, and this field is going through constant evolution, and we are trying to make this treatment more and more efficacious. And the beauty is it's just one-time infusion. And, I used to call it, or this kind of treatment, I call them live drug. That means once you give the cells, those cells, they stay in your system, they expand, they identify the cancer cells, they kill them off, and then they can stay there and prevent any future relapse.
That's
so
amazing.
They can stay there as memory cells. So it's really beautiful and fascinating.
Now, when you talk about shipping off the T cells, and I suppose the cancer cells themselves from a patient, are those unique? Is that cancer cell in that one patient unique to that patient from a DNA structure, or is that particular type of cancer sort of generic? I'm wondering about off-the-shelf use. What is the unique part that prevents you from just going, oh, here, let me give you this particular product that's sitting here on my shelf versus having to have it manufactured specifically to the individual?
That's a great question, Brian. And, right now, the CAR T cells, we are primarily using autologous CAR T cells. That means we are harnessing the immune cells from the patient itself.
Right.
And then we are genetically engineering it with the receptor, which works against a particular cancer type. And that kind of depends on the protein antigen, which is expressed on the surface of the cancer cells.
Okay. So that's a unique component.
Correct. And now we are also, and we have clinical trial utilizing allogeneic CAR T cells, which means you already have off-the-shelf product from a healthy donor, and that product is, sitting there. As soon as you diagnose a patient with relapsed refractory lymphoma or myeloma, you don't even need to collect their cells or wait for 3 to 4 weeks to get the product back. You can just use that off-the-shelf product, which is from a healthy donor, and you can give it straight to the patient. So it certainly saves you those 3-4 weeks of wait time.
That is amazing. Yeah. And I've been talking with the OHC folks now for years. My initial cancer diagnosis was in 2018, and you guys have been on my program since before I even was diagnosed with cancer. So I've been following, and just with the wildest amazement, the development of this CAR T. And I know that someday, maybe like next week, you'll be in here talking about, no, it's on the shelf right now. We have moved past this waiting period. All these different types of cancers can be addressed with this basically down the road off the shelf product. I'm excited for that, and I cannot thank OHC enough for being on the cutting edge doing these clinical trials, because this is where it all happens, folks. Clinical trials going on right now at OHC. They always are. So if you want to, the best advice I can give you, if you get the cancer diagnosis, we can all agree it sucks, but do what I did. Call OHC or get a second opinion. It's 888-649-4800. 888-649-4800. To learn more, go online. It's ohcare.com. Doctor, thank you so much for what you're doing each and every day. I really get enthused and actually extremely hopeful when I talk to you folks. So keep up the great work.
Thanks again, Brian, for having me here.
Good having you in studio.
Always a pleasure.
Good having you in studio. 8:56, folks. Like I said, listen to Todd.